Так, я листаю, да?
Да.
Когда закончу, что?
Просто не говорите, я закрываюсь.
Хорошо. Good morning, dear students. Our topic today, angina pectoris, one of the most common variant of stable ischemic heart disease or coronary artery disease. According to international classification of ischemic heart disease, angina pectoris in second place, and ischemic heart disease include some variants such as sudden coronary death, angina pectoris, acute MI, acute myocardial infarction, painless myocardial ischemia, heart failure, and disturbances of rhythm and conductivity. If you remember, coronary arteries supply blood to the heart muscle. Right coronary artery supplies both the right and the left heart, and the left coronary artery supplies the left heart. Left coronary artery divided on anterior coronary artery and circumference branch of left coronary artery. What does it mean, ischemic heart disease? Ischemic heart disease or coronary artery disease is the most common form of the heart disease and the single most important cause of premature death in Europe, Russia, North and South America, Australia and New Zealand. And ischemic heart disease due to disbalance between myocardial oxygen supply and oxygen demand, which associated with atherosclerosis of coronary arteries in 95 to 98% of all cases. Angina pectoris, clinical symptom or clinical syndrome, complex caused by transient myocardial ischemia and may occur whenever there is an imbalance between myocardial oxygen supply and demand. Angina pectoris is a medical term used to describe chest pain caused by poor blood flow to certain areas of the heart muscles. Often the name is shortened to angina. Having angina means patients have an increased risk of having a heart attack, myocardial infarction. Angina can be a useful warning sign if it makes patients seek timely medical help and avoid a heart attack. Usually, angina have a typical chest pain, pressure or chest discomfort. Heart is not receiving enough oxygen due to narrowed coronary artery, due to atherosclerosis of coronary artery. In the development of ischemic heart disease or coronary artery disease occur some risk factors, which divided on two main groups, non-modifiable and modifiable. Non-modifiable uncontrolled and modifiable controlled risk factors. Non-modifiable include age, more than 45, male gender, family history or genetic predisposition, and ethnic origin. Modifiable risk factors include dyslipidemias, arterial hypertension, smoking, diabetes mellitus, obesity, fatty food diet, physical inactivity, stress, and hyperestrogenemia in females. I think these men have some modifiable and non-modifiable risk factors, such as age, male gender, and obesity, smoking, and fatty food diet. The main reasons, etiology of angina include, at first, atherosclerosis. In as many as 96% of all cases, at least one blood vessel of the heart has severe coronary blockage. Critical blockage of a coronary artery from atherosclerotic plaque built up. When cholesterol or blood fats are too high or patients have other risk factors, a fat-like material called atherosclerotic plaque builds up in blood vessels. Eventually, the plaque will block blood flow through the vessel. And except atherosclerosis, maybe vasoconstriction, which cause angina pectoris, emotional stress, decreased oxygen content in the air you breathe, flying or being at high altitude may trigger angina. Coronary spasm is also called variant angina, Prinzmetal angina. Usually occur at night in males before morning and no response to nitroglycerin, and usually relief after calcium channel blockers, phenylalkyl origin like verapamil, diltiazem in tachycardia or dihydropyridine origin in bradycardia. First clinical signs and symptoms of angina appears if coronary artery narrowed more than 65% of diameter due to atherosclerosis, due to cholesterol deposition. Incidence of angina continuously rises with age in male and in female, and in women, while in men the incidence of angina peaks between 55 and 65 years of age before declining. Also, angina pectoris is of a great interest. There is a lack of data on a community-wide basis because it's very difficult to study. If you reveal chest pain, cardiac chest pain, we are suspect about, at first we are suspect about angina, and for verification of diagnosis, we must establish typical criteria of angina according characteristics. Ischemic cardiac chest pain characterized by location, central, diffuse, retrosternal pain. Radiation may be to jaw, neck, shoulder, arm, to back. Character usually burning, squeezing, choking, pressing, tight pain. Duration usually less than 15 minutes and most common 3 to 5 minutes. And provoking factors, physical exertion and emotional stress. And relieving factors, rest and quick response to nitroglycerin. Maybe associated features such as breathlessness, chest discomfort. There are signs and symptoms of angina as well. Uncomfortable pressure, fullness, squeezing or pain in the center of the chest, pain spreading to your shoulder, neck or arm and lasting more than few minutes. It may feel like pressure, tightness, burning, or heavy weight. It may be located in the chest, upper abdomen, back, neck, jaw, or inside arms or shoulders. Maybe anxiety, nervousness, or fainting, sweating, nausea, increasing of irregular heart rate, and disturbances of rhythm and conductivity. Chest pain may be caused by insufficient blood flow from partial blockage of the coronary artery. Usually substernal, diffuse, central, burning, pressing, pain with possible areas of radiating neck, jaw, upper abdomen, shoulders and arms. It's typical chest pain. This man suffered from angina. And according guidelines, traditional clinical classification of chest pain include three main criteria. Typical angina, substernal, characterized by substernal chest discomfort of characteristic quality and duration. Second criteria, provoked by exertion or emotional stress. And third criteria, relieved by rest and or nitrates within minutes. Atypical angina, probable angina, meets two of these characteristics, two of these criteria. And if you reveal only one or none of the criteria, it's non-anginal chest pain, cardialgia, non-coronarogenic pain. According clinical signs and symptoms, angina pattern is divided on stable angina, unstable angina, and Prinzmetal or variable angina, and microvascular angina. One of the variants of stable ischemic heart disease, one of the most important form of ischemic heart disease, stable ischemic heart disease, it's stable angina. Stable angina is a repeating pattern of chest pain which has not changed in character, frequency, intensity, or duration for several weeks or months. The level of activity or stress that provokes angina is predictable and the pattern changes slowly. Stable angina is the most common form and it appears gradually. These patients have an increased risk of a heart attack, but an episode of stable angina does not indicate that a heart attack is about to happen. Crucial component of the management of the pain associated with angina patterns is identifying sources of stress and creating effective methods to minimize stress. Relaxation techniques to reduce stress include meditation, listening to music, prayer, and exercise. The reason for the benefits that emerge after a coronary patient implements relaxation techniques are not clear. However, important roles appear to be played by central neural transmitters including serotonin, melatonin, epinephrine, and dopamine. But remember that stable angina usually occur in atherosclerosis of coronary arteries in 95 to 96%. If patients have stable angina, according to Canadian Cardiovascular Society, we are established four functional classes. And Canadian Cardiovascular Society separates patients with angina pectoris into groups based on severity and their symptoms. According to severity, first class, no limitation of ordinary activity. Walking or climbing stairs does not cause angina. Angina may occur with unusual, strenuous, rapid or prolonged exertion. Second class, characterized by slight limitation of ordinary activity. Angina may occur with walking or climbing stairs rapidly and or walking more than 200 meters or climbing more than one flight of stairs at a normal pace and in normal condition. Third class of stable angina, characterized by marked limitation of ordinary activity. Angina may occur after walking from 100 to 200 meters or climbing one flight of stairs at a normal pace and in normal condition. And severe class. Fourth class, unable to carry on any physical activity without chest discomfort. Any physical exertion can cause angina and may be present at rest. The same information and its table according to the last guidelines of European Society of Cardiology. 2019. First class angina only with strenuous exertion, second class angina with moderate exertion, third class angina with mild exertion, and fourth class angina at rest. Unstable angina. Unstable angina is a chest pain that is variable, either increasing in frequency or intensity and with irregular timing or duration. Unlike stable angina, unstable angina does not appear gradually. It first appears as a severe episode, and established stable angina might change suddenly or be provoked by less stress than in the past, or an episode might suddenly occur while at rest. If the pattern of an episode changes, for example, if a previous episode was only brought on during physical exertion, but an episode suddenly occurred at rest, it's likely to be unstable angina. Unstable angina separates on new onset angina pectoris from first clinical signs of substernal pain or chest discomfort till 28 days. Second variant of unstable angina, progressive angina pectoris, which characterized by increased intensity and duration of pain, increased quantity of attacks, the appearance angina at rest and or at night, increased class of angina, progressive decreased tolerance to physical exertion, transient ischemic changes on ECG at rest. Third variant of unstable angina, early post-myocardial infarction angina pectoris from 3 to 28 days. And fourth variant, angina at rest. How we distinguish stable and unstable angina? In stable angina occur fixed stenosis of coronary arteries. In unstable, dynamic stenosis, sometimes due to rupture of atherosclerotic plaque and acute thrombosis of coronary arteries. In stable angina occur demand-led ischemia. In unstable, supply-led ischemia. In stable angina related to effort. In unstable, unpredictable. Stable angina predictable and symptoms over long term. In unstable, symptoms over short term. In stable angina, symptoms on minimal exertion should be. In unstable, frequent or nocturnal symptoms. In stable angina, exercise testing provoked chest pain and ECG changes. And in unstable angina, ECG changes occur at rest and characterized by severe symptoms. What does it mean, Prinzmetal angina? Prinzmetal angina, or spontaneous or angiospastic angina, caused by vasospasm, or spasm that narrows the coronary artery and lessens the blood flow to the heart. Prinzmetal angina usually occurs in arteries already narrowed by atherosclerosis. In fact, most people with it have severe coronary atherosclerosis in at least one or major vessel. Spasm usually occurs very close to blockage. Unlike stable and unstable angina, Prinzmetal angina usually occurs when a person is at rest or sleep, often at night. Usually man, and not after physical exertion or emotional stress. Sometimes it's associated with acute MI, severe cardiac arrhythmias, including ventricular tachycardia and fibrillation, and sudden cardiac death. And in Prinzmetal angina, a response to nitroglycerin absent and pain relief after calcium channel blockers usage. Microvascular angina or stable angina pectoris in angiographically intact vessels or coronary syndromics, not same with acute coronary syndrome. Microvascular angina occurs when the patient experiences chest pain but has no apparent coronary artery blockage. This condition results from poor functioning of the tiny blood vessels that nourish the heart, arms, and legs. Microvascular angina can occur during exercise or at rest. Reduced vasodilator capacity of the coronary microvessels is thought to be a cause of angina during exercise, but the mechanism of angina at rest is not known. Coronary microvascular spasm and resultant myocardial ischemia may be the cause of chest pain in a subgroup of patients with microvascular angina. And now the main reason of microvascular angina it's dysfunction of vessels, endothelial dysfunction. And microvascular angina characterized by three specific typical signs. First, classic angina, chest pain, anginal chest pain. Second criteria, ST segment depression on ECG during stress test. And third criteria, angiographically normal coronary arteries without left ventricle dysfunction on echocardiography. We establish diagnosis after coronary angiography and after echocardiography. Diabetes mellitus is one of the most important risk factors which can cause atherosclerosis. Diagnosis of angina pectoris is clinical diagnosis. Usually involves a careful assessment and history of signs and symptoms in 80 to 90% of all cases of patients. Diagnostic procedures to exclude angina or establish the severity of coronary heart disease include ECG, stress test, coronary angiography. ECG records electrical impulses of the heart which enable one to assess if the heart muscle is not getting sufficient oxygen or if there are abnormal features of the heart. Stress test is used to detect coronary artery disease and to determine safe levels of exercise. In a coronary arteriogram, coronary angiography, are taken after a contrast agent is injected into an artery to locate the narrowing, occlusions, and other abnormalities of specific arteries. There are a few conditions which mimic angina. And coronary angiography is the gold standard of diagnosis of ischemic heart disease. Laboratory investigations include routine methods such as obligatory indicators, CBC, hemoglobin level at first, for excluding of anemia which can cause insufficiency of oxygen. Total cholesterol, high density cholesterol level, low density cholesterol level, triglycerides, all components of lipid profile, obligative methods for investigation, glucose, AST, ALT, creatinine for calculation of glomerular filtration rate. And if patient need additional indicators such as cardiac troponins and thyroid function such as T3, T4, TTH for exclusion of pathology of thyroid gland. Instrumental investigation include resting ECG, reversible ST depression or elevation with or without T-wave inversion, at the time the patient is experiencing symptoms. But if you review ECG changes, it's no exclude ischemic heart disease. Exercise ECG, standard treadmill test or bicycle ergometer protocol, planar or downsloping ST depression of 1 mm or more is indicative of ischemia. And except ST depression should be ST elevation, subepicardial ischemia, and subepicardial ischemia usually typically for Prinzmetal angina, angiospastic angina. And Holter monitoring ECG during 24 hours usually we are used for revealing of painless variant of ischemic heart disease. And painless ischemia occur more than twice than pale variant. Myocardial perfusion scanning helpful in patients who are unable to exercise. Its predictive accuracy is higher than that of the exercise ECG. Stress echocardiography to identify ischemic segments of myocardium and areas of ischemia or areas of acute MI exhibit reversible defects in contractility during exercise or pharmacological stress with dobutamine. Coronary arteriography provides detailed anatomical information about the extent and nature of coronary artery disease and is usually performed with a view to coronary bypass grafting or PCI, percutaneous coronary intervention. Stenting may be indicated when non-invasive tests have failed to elucidate the cause of atypical chest pain. According to last guidelines of European Society of Cardiology, resting transthoracic echocardiogram is recommended in all patients for first, exclusion of alternative cause of angina. Second, identification of regional wall motion abnormalities suggestive of coronary artery disease. Third, measurement of left ventricle ejection fraction for risk stratification purpose. And fourth, evaluation of diastolic function. Ultrasound of the carotid arteries should be considered and be performed by adequately trained clinicians to detect plaque in patients with suspected Canadian Cardiovascular Society without known atherosclerotic disease. CMR may be considered in patients with an inconclusive echocardiography test. In this case, we can see ST depression in first, AVL, and from chest leads, from V1 to V6. It's extensive subendocardial ischemia due to atherosclerotic plaque in coronary arteries of anterior wall, and it's subendocardial ischemia In this case, opposite changes. In first AVL and from V2 to V5, you can see ST elevation, subepicardial ischemia. And in this case, we are established acute coronary syndrome with ST elevation. And if you now review R wave in V3, we are suspect about acute transmural MI, formation of QS. Coronary angiography, left anterior descending part of left coronary artery, characterized by narrow of diameter. Management of angina pectoris involves first, careful assessment of the likely extent and severity of coronary artery disease. Second, identification and control of significant risk factors. Third, use of measures to control symptoms. And fourth, the identification of high-risk patients and application of treatment to improve life expectancy. Lifestyle modification, one of the methods of non-pharmacological treatment. And at first, saturated fatty acids to account for less than 10% of total energy intake through replacement by polyunsaturated fatty acids. Second recommendation, trans-unsaturated fatty acids less than 1% of total energy intake. Less than 5 grams of salt per day. And 30 to 45 grams of fiber per day from whole grain products, fruits and vegetables. 200 grams of fruits per day and 200 grams of vegetables per day. Fish at least twice a week, one being oily fish. Consumption of alcoholic beverages should be limited to 2 glasses per day, 20 grams per day of alcohol for men, and 1 glass per day, 10 grams per day of alcohol for non-pregnant women. Typical diet for patients with ischemic heart disease. Pharmacological management of patients with stable coronary artery disease or stable angina separates on two main directions. At first line, angina relief, and second line or second direction, event prevention. For angina relief, we used at first short-acting nitrates, nitroglycerin sublingually in tablets or Isocate spray, and anti-ischemic drugs for prevention of further attacks of angina. First line, include beta blockers or calcium channel blockers which decrease heart rate, verapamil or diltiazem. We consider calcium channel blockers dihydropyridine origin if low heart rate or intolerance or contraindications for beta blockers or calcium channel blockers heart rate decrease occur. And if we review angina pectoris more than second functional class according to Canadian classification, we consider combination of beta blockers plus calcium channel blockers, dihydropyridine origin. If no effect, if no response to combination of two anti-ischemic drugs, beta blockers plus calcium channel blockers, such as amlodipine or lercanidipine or felodipine, may add or switch first line for some cases. And we use second line of management. And second line of pharmacological drugs include ivabradine, long-acting nitrates, nicorandil, ranolazine, trimetazidine. And if no effect, if no response to third or fourth drugs, anti-ischemic drugs, we consider coronary angiography and invasive strategy, percutaneous coronary intervention, stenting, or CABG, coronary artery bypass graft. Second direction of management of stable angina, even prevention. Even prevention, or include even prevention include lifestyle modification for reduce risk factors or remove risk factors with control of risk factors. And non-pharmacological method include education of patients for minimization of risk factors. And pharmacological management include three main groups of drugs. Acetylsalicylic acid, aspirin, hypolipidemic drug, usually statins. And third group, consider ACE inhibitors or angiotensin II receptor blockers. If intolerance or contraindications for ACE inhibitors occur. And according to last guidelines of European Society of Cardiology, pharmacological management include 4 steps. And first step depends on heart rate. If you remember heart rate, the same risk factors of cardiovascular diseases. If heart rate more than 80 beats per minute, first line of management, beta blockers or non-dihydropyridine calcium channel blockers, verapamil or diltiazem. If low heart rate occurs, we use dihydropyridine origin calcium channel blockers, amlodipine or lercanidipine or felodipine. If left ventricle dysfunction or heart failure occur? First line of management, beta blockers. Second step depends on heart rate. If heart rate more than 80, we use combination beta blockers plus calcium channel blockers. If low heart rate, switch to LAN. If left ventricle dysfunction or heart failure occur, can use beta blockers or long-acting nitrates or beta blockers or plus ivabradine combination. If low blood pressure, switch to ivabradine, ranolazine or trimetazidine, second line of anti-ischemic drugs. Third step, if heart rate more than 80 beats per minute, can use combination beta blockers plus ivabradine. If low heart rate less than 50, can use dihydropyridine origin, calcium channel blockers, amlodipine, plus long-acting nitrates. If left ventricle dysfunction or heart failure occur, can add another second-line drug. If low blood pressure, combine two second-line drugs, such as ivabradine, long-acting nitrates, nicorandil, ranolazine or trimetazidine. And fourth step, if no effect after 2 or 3 drugs, may add nicorandil, ranolazine or trimetazidine. Short-acting nitrate nitroglycerin is a drug most often used, mainly relax the peripheral vasodilator. Short-acting relax veins and relax the coronary arteries. By relaxing the veins, it reduces the amount of blood that return to the heart and eases the heart workload. By relaxing the coronary arteries, it increases the heart blood supply. The heart's demand for oxygen also can be modified with drugs that reduce blood pressure. This reduces the heart workload and need for oxygen. Drugs that slow the heart rate have a similar effect. Drugs called beta blockers and calcium channel blockers are used for this effect. There are many different beta blockers and calcium antagonists, and the specific ones used are selected depending on the individual characteristics of each patient. Beta blockers, metoprolol, bisoprolol, cardioselective beta blockers, and nebivolol and carvedilol, first line of management of anti-ischemic therapy. Calcium channel blockers include verapamil and diltiazem, non-dihydropyridine origin, and amlodipine and lercanidipine and felodipine if low heart rate and if beta blocker contraindicated. Nitrates include isosorbitadienitrate, isosorbitamononitrate. Potassium channel activators same one of the group of drugs which we are using for anti-ischemic therapy. Drugs which improve prognosis for event prevention. Antiplatelets, acetylsalicylic acid or clopidogrel, or prasugrel or ticagrelor or can use. Statins, lovastatin, simvastatin, atorvastatin, rosuvastatin. Beta blockers can use the same improved prognosis. And AC inhibitors, enalapril, lisinopril, perindopril, ramipril. For prevention of remodulation of myocardium in ischemic heart disease. Antiplatelet therapy, low dose of aspirin, 75 to 150 mg, reduce risk of adverse events such as myocardial infarction and should be prescribed for all patients. Clopidogrel, 75 mg, is an equally effective agent that can be prescribed if aspirin causes dyspepsia or other side effects, and if aspirin contraindicated in peptic ulcer. Except pharmacological management, invasive techniques that improve the heart and the heart's blood supply also may be used. One of these, percutaneous coronary angioplasty or percutaneous coronary intervention, angioplasty, balloon dilatation, balloon angioplasty, same. And usually now we use stenting. Coronary artery bypass graft surgery is also used. In it, a blood vessel is used to route blood around the blockade part of the artery, forming a kind of detour. Before performing any of these procedures, a doctor must find the blockade part of the coronary arteries. This requires coronary arteriography, which is done during cardiac catheterization. In this procedure, a doctor guides a catheter through an artery in the arm and into the coronary arteries. Then the doctor injects a liquid dye through the catheter. High-speed X-ray movies record the course of the dye as it flows through the artery. Doctors can identify blockages by tracking the flow. An evaluation of how the heart works also can be done during cardiac catheterization. Other tests can be used to evaluate how well the heart works and may be done before or after a heart attack. How is variant angina or Prince metal angina treated? Calcium channel blockers are extremely effective in preventing the coronary spasm of variant of Prince metal angina. These drugs, along with nitrates, are the mainstays of treatment. Prince metal angina tends to be cyclic, appearing for a time, then going away. Because of this, after 6 to 12 months of treatment, the calcium channel blockers may be gradually reduced. In some cases, percutaneous coronary intervention or CABG are used when blockage exists along with spasm. Pharmacological management will depend on severity of symptoms, severity of the underlying disease, and extent of damage to the heart muscle, if any. Simple rest and observation, when aspirin, breathing oxygen, and sublingual nitroglycerin may be all that you need. If it is only injected, you may be given medication to reduce anxiety or to treat pain. You may be given medication to lower blood pressure or heart rate, beta blockers, AC inhibitors, and cholesterol-lowering drugs, statins, are commonly given if the chances of a heart attack are likely. You may be given medication to reduce the risk of having a blood clot or to prevent further clotting. If the healthcare provider believes chest pain actually represents a heart attack, you may be given a powerful clot buster medication called a fibrinolytic. But fibrinolytic usually we use in acute coronary syndrome with ST elevation. Usually it's acute-amine. No use in stable angina. Cardiometabolic therapy include trimetazidine, ribaxine, mildronate, vitamins and antioxidants. It's second line of management, no improved prognosis. After reviewing your immediate test results, the hospital healthcare provider will make a decision about where you should be for the next hours and days. If you care feeling better, your condition is stable, and this was only an angina attack, you may be allowed to go home. You may be given medication to take. You will be told to follow up with your primary care provider within the next day or two. If you keep having symptoms or your condition is unstable, you will be admitted to the hospital. You will probably undergo further tests and possible coronary angiography, coronary artery angioplasty, or even coronary artery bypass surgery if all your arteries are critically blocked. Invasive management. Angioplasty is a treatment used for people whose angina does not get better with medication and or who are at high risk of having a heart attack. Before angioplasty can be done, the areas of coronary artery narrowing is located with coronary arteriography. A thin plastic tube called a catheter is inserted into artery in the arm with local sedation. The catheter has a teeny balloon attached to the end. The catheter is threaded through the arteries and into the artery where the narrowing is. The balloon is inflated, opening up the narrowing. This is not permanent solution for most people. Many require replacement of a stent, a small metal sleeve that is placed in the narrowed artery. The stent holds the artery open. Percutaneous coronary intervention, angioplasty. Catheter entrance into artery. Now arm artery, a balloon-tipped tube is inserted into coronary artery. But sometimes occur adverse effect, maybe dangerous procedure and rupture vessel. And now we use usually stent insertion and stent expansion. Stent remains in coronary artery. Restoration of coronary circulation. What is new according to last guidelines of European Society of Cardiology in diagnosis and in management of chronic coronary syndrome? Last guidelines have been revised to focus on CCS instead of stable coronary artery disease. This change emphasizes the fact that the clinical presentations of coronary artery disease can be categorized as either acute coronary syndrome or chronic coronary syndrome. In the current guidelines on chronic coronary syndrome, 6 clinical scenarios most frequently encountered in patients are identified. First scenario: patients with suspected coronary artery disease and stable anginal symptoms and/or dyspnea. Second variant: patients with new onset of heart failure or left ventricle dysfunction are suspected coronary artery disease. Third variant: asymptomatic and symptomatic patients with stabilized symptoms less than 1 year after an acute coronary syndrome or patients with recent revascularization. Fourth variant: asymptomatic and symptomatic patients more than 1 year after initial diagnosis or revascularization. Fifth variant: patients with angina and suspected vasospastic or microvascular disease. And last variant, sixth variant: asymptomatic subjects in whom coronary artery disease is detected at screening. New information. The pretest probabilities of coronary artery disease based on age, gender, and nature of symptoms have undergone major revisions. In addition, we introduced the new phrase clinical likelihood of coronary artery disease that utilizes also various risk factors of coronary artery disease as pretest probabilities modifiers. The application of various diagnostic tests in different patients groups to rule in or rule out coronary artery disease has been updated. The guidelines emphasize the crucial role of healthy lifestyle, behaviors, and other preventive actions in decreasing the risk of subsequent cardiovascular events and mortality. Basic, basic testing, diagnostics, and risk assessment. Non-invasive functional imaging or coronary CTA as an initial test for diagnosing coronary artery disease. Initial non-invasive diagnostic test based on the clinical likelihood of coronary artery disease patients' characteristics, local expertise, and availability. Functional imaging for myocardial ischemia if coronary CTA has shown coronary artery disease of uncertain functional significance or is not diagnostic. Class 1. Invasive angiography to diagnose coronary artery disease in patients with a high clinical likelihood and severe symptoms refractory to medical therapy. Class 1. Typical angina at low level of exercise and clinical evaluation that indicates high event risk. Class 1. Invasive functional assessment must be available and used to evaluate stenosis before revascularization unless very high rate, more than 90% diameter stenosis. Class 1. Invasive coronary angiography with availability of invasive functional evaluation for confirmation of coronary artery disease diagnosis in patients with uncertain diagnosis or non-invasive testing. Class 2A. Coronary CTA as an alternative to invasive angiography if another non-invasive test is equivocal or non-diagnostic. Class 2A. Coronary CTA when any conditions make good image quality unlikely. Class 3, no use. Antithrombotic therapy in patients with CCS and sinus rhythm. Adding a second antithrombotic drug to aspirin for long-term secondary prevention in patients with high risk of ischemic events and without high bleeding risk. Class 2A. Adding a second antithrombotic drug to aspirin for long-term secondary prevention in patients with at least a moderately increased risk of ischemic events and without high bleeding risk. Class 2A. Class 2B. Antithrombotic therapy in patients with CCS and atrial fibrillation. Anticoagulant is recommended in preference to a VKA. Long-term anticoagulant therapy in patients with atrial fibrillation and a CHA2 VASC score more than 2 in males and more than 3 in females. Class 1. First position, new oral anticoagulants such as rivaroxaban, apixaban, dabigatran. Long-term oral anticoagulant therapy in patients with atrial fibrillation and CHA2 VASC score in 1 in males and 2 in females, class 2A. And antithrombotic therapy in post-PCI patients with indications for oral anticoagulants. First position. Full dose new oral anticoagulants is recommended in preference to warfarin. Rivaroxaban 50 mg over 20 mg, dabigatran 110 mg over 150 mg. Early cessation less than 1 week of aspirin. Triple therapy for 1 to 6 months. INR 2 to 2.5 and TTR more than 70% if warfarin. It's class 2A. Duotherapy with prasugrel or ticagrelor or clopidogrel, class 2B. Other pharmacological therapy. A PPI in patients receiving aspirin monotherapy, dual antiplatelet therapy, or oral anticoagulants monotherapy who are at high risk of gastrointestinal bleeding. Ezetimibe of lipid goals not achieved with statins, class 1. A PCSK9 inhibitor in patients at very high risk who do not achieve lipid goals with statins and ezetimibe. Its new position, class 1. Sodium glucose cotransporter 2 inhibitor in patients with diabetes mellitus and cardiovascular diseases. Glucagon-like peptide 1 receptor agonist in patients with diabetes mellitus and cardiovascular diseases, class 1. ACE inhibitors in patients at very high risk of cardiovascular adverse event, class 2A. Screening for coronary artery disease in asymptomatic subjects. Carotid ultrasound (IMT) for cardiovascular risk assessment is not recommended. Class 3. Treatment options for refractory angina. Coronary sinus constriction for debilitating angina refractory to optimal medical and revascularization strategies. Class 2B. Thank you for attention. Be healthy. I wish you success.
Дима, может